Jessica Stith. I am the manager of the Virtual Health Center with St. Elizabeth Physicians. So that if you're not familiar with St. Elizabeth, we have two kind of entities, the physician side and the healthcare side, serving Northern Kentucky. And our virtual health center, what encompasses under our center, we do have a remote patient monitoring program. We have a 24/7 nurse triage line. We have a designated team of 6 nurse practitioners completing our telehealth visits. And we also have a school-based health program. Then we are integrated into 9 different school districts in Northern Kentucky. And then our services in the virtual health realm then also bleed into the inpatient setting, so the healthcare side, where we do have a virtual observation program and a telemetry monitoring program. So today we are going to focus on the integration of some of the virtual health workflows into the post-acute setting. So really kind of what I mean by post-acute setting, kind of looking at the skilled and long-term care facilities. Quick overview of the agenda. Talk about identifying the needs in those facilities, our implementation and workflow design, and then of course barriers that we did encounter, and our impact and outcomes. So really when we were first kind of investigating what virtual services were needed, there was an overarching theme that was evident throughout, and that was really the need to increase clinical accessibility. So increase that timely accessibility from the nursing facility perspective, so their staffing teams, and then of course patient family, their clinical accessibility, and then that geriatric provider support. One rounding geriatric provider for an entire facility simply cannot meet the needs of every single resident or patient at that facility. And then kind of looking at that accessibility constraint, if we recognize that there was a need to drive appropriate healthcare system utilization. I think we all know when we have delayed care, delayed clinical access, that often leads to increased readmissions. It leads to routing to the emergency room inappropriately, just not utilizing our healthcare system appropriately because we are just trying to make ends meet. So with that being said, one of the first kind of phase that we identified was to implement a 24/7, 365 nurse triage model within the post-acute facilities. Really the goal was to kind of to collaborate with those facility staff members, those nurses, and the geriatricians that are rounding there, and kind of be that encompassing piece. So kind of be that go-between to help facilitate some of those clinical questions, patients and family, of course, as well. Just making sure the care was met in a timely manner. And before, implementing the nurse triage 24/7, we did already have a triage program, like I had mentioned, up and running in our virtual health center. But really, it was kind of, are we going to be able to do this? What is the lift? What is this going to look like? So some first considerations is really, honestly, when I'm looking at implementing any new process or taking on any new project with our triage team, it sounds very granular, but it's looking at that volume. And not just that volume per month or per week, but it's getting down to that call volume as far as per hour, per day, and really looking at the impact. Can we take on this service and provide it well with our existing teams, or are we going to have to increase FTEs, things like that. Once we were able to examine that call volume and feel confident that we had a proposed staffing model that we were going to be able to provide the service, then of course kind of collaborating with our third-party phone systems, just keeping mindful of all the different entities that just rolling out a new program was going to impact. And then kind of the next phase, I would say, when we were trying to implement this was we were really heavy on education. So education, of course, first and foremost with our existing team, rolling out a new project, change can be hard, but then really heavy education within the post-acute facility. So we spent a lot of time rounding at each facility, various different facilities. We met with the facility admin, staff there, really just trying to understand their workflow, trying to understand what their daytime needs are. They have differing needs after hours. We were obviously taking their calls after hours as well. So just making sure we were going to be able to support those needs, and really educating also what our services were, what nurse triage was. We are a team of nurses utilizing the Schmidt-Thompson protocol. I'm sure many of you in this room are familiar with that, but even in the community, not everybody understands, what the limitations are from the nursing perspective, what we are able to do. So heavy on that education within the facility. And then we spent kind of a lot of time then meeting with the geriatric providers. So heavy education, just again, kind of walking through protocols. Many can appreciate there's a lot of times there's some provider hesitation. So really just, again, kind of spending time, letting them dive deep into our protocols, making sure we felt like there was alignment, and, being mindful of the geriatric population, which is vulnerable in many different ways. And then patient family education, just making sure that patients and families were aware of this service. It doesn't necessarily only have to be the staff from the nursing facilities calling. It certainly can be a family member just trying to get caught up on some clinical information. The providers rounding in the facilities, if you are a working family member, you're probably not there when your provider was rounding on mom, dad, and you're in the nursing home. So it's kind of being able to piece all of that together, be that sounding board, answer those clinical questions, because we've talked already about some staffing issues that we all have felt throughout. That is also, we know, in the nursing homes and those post-acute facilities. So it's really also kind of to be that support for the nursing teams, so they don't have to take away time from patient care answering some of those questions. And then, of course, before any kind of rollout, it was getting a good understanding of that baseline data. So we knew, and we were hoping and anticipating we were going to make some movement as far as ED utilization from the post-acute facilities and readmission rates. And so really just understanding each facility, what their rate was, and looking at our ED utilization at our system. Second phase that we identified to augment that clinical accessibility was implementing our video visits on demand. Like I mentioned, we had already have a team of 6 wonderful nurse practitioners completing these video visits, but this really was, we weren't completing these visits in these post-acute facilities. The geriatric providers were rounding, it was never an identified need previously, but being able to go ahead and stand up the video visits at the facilities was going to allow for that expanded provider coverage. So after hours, the virtual video visits are available until 10 p.m. at night. So it's really, being able to see some of those appropriate video visit types and address common illnesses after hours, and then even augment the support that the providers have during the day. Providers certainly can't see every single patient there at the facility, and of course, kind of when those acute illnesses would pop up, cold, fever, UTI symptoms, things like that, if they were already kind of at their capacity for today, is it appropriate for a video visit? Can we go ahead and slide this patient into one of those visits and get their needs met? And again, just thinking about that utilization of the healthcare system, more timely interventions to hopefully prevent that admission to the emergency room. So some considerations before being able to jump in and roll out the video visits at the facilities is, of course, kind of the equipment needed. These were community partnered facilities. They weren't a St. Elizabeth facility, so who is purchasing and buying the equipment? Who's going to upkeep the equipment? And whose responsibility, and just kind of education around all of that. And then, of course, legal teams. Every facility had a different legal team. Of course, St. Elizabeth has a legal team, and just making sure we had proper consent in place. And then the kind of next phase was really making sure we have the virtual providers and the geriatrician providers collaboration on the same page, as far as video visit alignment, what are we going to be able to pivot to a video visit, that handoff piece, that follow-up piece for the next day, even as granular as, if we're ordering labs, things like that, is the virtual provider following up, or is that going to be that geriatrician following up the next day? things like that. So, and again, heavy on the patient, family, and staff education piece. Just, I feel like a lot of these services oftentimes are driven by the staff, driven by our healthcare workers who are there at the bedside and, really kind of being the voice and augmenting this process. So what does all this look like when we kind of put both of these phases together, and again, trying to increase that clinical accessibility and more timely management of the patient? High-level overview of our kind of process would be a facility calls the geriatric office. So that could be that facility staff member, that could be a patient, family. And then, like at most phone trees, they're going to have the option to speak to our Nurse Now program. So that is our telehealth nurse program there, and they're going to answer the phone and they're triaging that call. Again, they're going to triage that call utilizing the Schmidt-Thompson protocol set. So they are going to have that clinical backing for the decisions that they're making. It is also important to us that it is a team of RNs that are triaging these calls, because we look at the protocol set to augment their clinical decisions. We like for them to be able to utilize their clinical judgment. They are nurses. We want them to have that protocol set, but then also have that nursing backing as well. And then from there, it's making those decisions. Is this something that needs to be addressed in an hour? Do I need to page the provider via secure chat, have that communication with the provider? Or is this something that, the provider, the geriatrician certainly needs to know about it, but we don't need to interrupt their day. We don't need to interrupt their rounding. We can route this message to the clinical pool for the next day follow-up. Or, depending on the time of day or the capacity of the rounding geriatrician, is this appropriate for a video visit? Can we go ahead and slide this patient, get this patient's needs met, get meds ordered, get testing done? And then, of course, while we would certainly aim to avoid at all possible, if we do, and there are certain situations where we would have to route patients to the emergency room, so just sending that FYI to the provider as well. Some barriers that we did encounter, I kind of mentioned earlier. We did, that initial provider hesitation. So our nurse triage team, we do take after-hours call for the entire St. Elizabeth organization, so all of primary care as well as the specialty care offices. The specialty care offices, we started taking their after-hours call a couple years ago, and that was a phased rollout. And I would tell you that there was probably each time we went to present and kind of explain the rollout that we were doing with these different specialty groups, there was always that initial hesitation. What is triage? What is the Schmidt-Thompson protocol set? What are you ordering? What are you doing? Can you order, and just kind of a lot of clarity around there. And I feel like once we were able to meet with providers and have that conversation and do deep dives into the protocol sets, every single time with our specialty providers, they've been blown away. They have been, well in alignment with the protocol set, and ultimately after rollout just are nothing but complimentary of, for one, we'd reduce their call burden after hours, right? But just also, I think the service that it does provide the patients. Facility associate and nurse buy-in. Change is hard, I mentioned, it both from the St. Elizabeth team side and then all of the different facility nurse team side, kind of just that understanding and encouragement to utilize video visits, utilize the Nurse Now line. Buy-in can be hard. And then timing of the video visit. So it's different than just our patients who were putting on the video visit on demand schedule. They are completing that visit on their own. Obviously, in the post-acute setting, those visits do need to have a facilitator there at the facility. So just making sure that timing is appropriate on both ends. Differing EMRs, I feel like that continues to be a challenge, not just with this project, but throughout our system. And of course, cost of equipment. Who's going to pay for new projects? And looking at impact, we kind of can bucket it in many different ways. So streamlined communication was probably a big one. It was not that delayed communication or getting the needs met from that facility team, trying to reach out to the provider who's rounding, who's maybe getting to that message or that patient hours later. And then two, so the messages or information that was given to the providers was more clinical details. It was more actionable, could hand off an order that we could get implemented fairly quickly. Family can participate in the care of the patient without being on site with completed those video visits. They can also join the visit. More appropriate ED utilization. Decreased readmission rates was reported at all of our facilities that we did implement this. And then, of course, the reduction of telephone encounters from the facility teams, just making a lot of those outbound calls, we were able to streamline that just going through the clinical side. Thank you.